This is the final session of our 2016 mini medical school, and we are truly delighted to have you here. This should be a wonderful evening. I'm really looking forward to hearing Dr. Suzanne Allen and two medical student panels talk about education and training physicians to work in WWAMI. So I'm Virginia Brody. I'm the Chief of Medicine at Harborview and Vice Chair of the Department of Medicine. And my co-host, Dr. Sinanen, is here. He's just arrived off the airplane. And UW Medicine's mission is to advance medical knowledge, to provide outstanding primary and specialty care to the people of the Pacific Northwest, and to train tomorrow's physicians, scientists, and health professions. And that's why we're so enthusiastic about hearing from our medical students, I believe from between the second and fourth year of medical school this evening. UW Medicine includes 8 entities: Harborview Medical Center, the University of Washington Medical Center, Northwest Hospital, Valley Medical Center, our primary care clinics, the UW neighborhood clinics, the physicians of UW Medicine, our School of Medicine, and Airlift Northwest. And our mission is to inform you about biomedical sciences from research to the bedside, to understand what's involved in being a medical student, and to invite you to partner with us in supporting excellence in medical science and patient care at UW Medicine, and of course, to have fun. And tonight is graduation night, so for those of you who have attended 4 or more sessions, we have a certificate for you, and we're also going to have a reception at the end of tonight's mini medical school session, and we hope you will come. The presentations are available the next day. Please turn off your cell phones, your pagers. And let me introduce Dr. Suzanne Allen, who will speak about rural medicine, tailoring WWAMI care to the Northwest's populations. And she is Vice Dean for Academic, Rural, and Regional Affairs at the University of Washington School of Medicine, a clinical professor in the Department of Family Medicine, and she sees patients at St. Alphonsus Regional Medical Center and St. Luke's Medical Center in Boise, and she's here with us tonight. She practiced family medicine at Ellsworth Air Force Base and Andrews Air Force Base. She has extensive national responsibilities with the American Academy of Family Physicians, and she serves on leadership councils for the ACGME and the Association of American Medical Colleges. So please help me in welcoming Dr. Suzanne Allen.
Thanks very much, Dr. Brody, and thank you very much for inviting me so I can talk about what we do with the School of Medicine and the WWAMI program. I have kind of 4 big areas that I want to cover tonight. So first I'm going to talk just a little bit about the physician workforce, since what we're doing is trying to train the future physicians for our region. Talk a little bit about what do you have to do to become a physician, then specifically about what we do in the School of Medicine and the WWAMI program. And I want to end a little bit with what we do around curriculum renewal, or how we've changed our curriculum this year. Then after I'm done talking, we'll take a short break, and we're going to have 2 panels of students. The first panel of students is going to talk a little bit about their experience with some of the rural programs that we have. And then the last panel of students is going to talk about their experience with the new curriculum. So first of all, the physician workforce. So the data on this particular slide actually comes from the Association of American Medical Colleges, as they showcase kind of how many physicians per capita or per 100,000 population you have around the US. So you can see the average in the US is 266 physicians per 100,000 population. And then you can see where each of the WWAMI states are as far as the number of physicians they have, and then their ranking if you rank all of the 50 states. So just to give you a little bit of perspective, Massachusetts is number 1. They're up a little bit over 300 physicians per 100,000 population. And in last place, or 50th, is Mississippi. So looking a little bit more specifically at the state of Washington, we know in the state of Washington, we actually did pretty well around the overall number of physicians per 100,000 population. This just gives you an idea about where you have the concentrations of physicians. So if you look at the counties here that are in the dark blue, these are the counties that tend to have more physicians in them per capita than the counties that have the lighter colors in them. So you can see kind of where that distribution is, mostly distributed based off of population centers, but not always exactly the way we'd want them to distribute. And then this slide looks specifically at generalist physicians. So primary care physicians, family physicians, general pediatricians, general internists, as well as general surgeons were included in this particular slide. And again, you can kind of see where it's darker green versus lighter green, where you get that distribution of physicians. So some of the things we work on as we train physicians is how do we get physicians to go to the right places where we need them the most to care for our population around the region. So now let's talk a little bit about what it actually takes to become a physician. So we talk a lot about starting all the way back in elementary school. So how do you get kids who are in elementary school interested in science? How do you get them interested in what's happening in the body so that they might have an interest in going into a health profession? Maybe not into medicine, but into some sort of a health profession. Certainly, once you get into college or university, there are maybe a few more specific things that we really have students doing. So we don't care what people get their major in when they go to college, but they do have to do a certain number of science prerequisites to be admitted into medical school. And then we're also looking for what are they doing as far as service to others? What are they doing as far as leadership? So those are things that we look for in applications when students apply to medical school. Then once you're in medical school, of course, it's 4 years of medical school. Everyone is working kind of on the same thing, and we'll talk a little bit more about the curriculum a little bit later on. Then you go into residency or graduate medical education. And this is really where you're differentiating into what kind of a physician are you going to be. So I'm a family physician, so I did a specific kind of residency to become a family physician. Dr. Brody did a different kind of residency program to go into her specialty. Dr. Sinanen did a different kind of residency to go into his specialty. And depending upon what specialty you go into is how much time you're going to spend in your training around residency. So for family medicine, it's 3 years. Then if you want to go on and specialize after you do your residency, you might do a fellowship. So to go and become an oncologist, Dr. Brody would have done an internal medicine residency for 3 years, and then she would have gone on and done an hematology-oncology fellowship after that. So that's where you get into the number of years of training that it takes to become a practicing physician. It's variable depending upon what specialty you want to go into, but it's anywhere between 11 years on after high school to become a practicing physician. So let's talk a little bit about what we do within the School of Medicine in WWAMI to create those physicians that can go out and care for people. So the University of Washington School of Medicine is the accredited School of Medicine for our 5-state region. Our acronym is WWAMI, Washington, Wyoming, Alaska, Montana, and Idaho. We actually started with just one W when we started back in 1971, and then Wyoming joined us in 1996. We have a partner university in each of our states. As many of you probably heard, we have a new partner university here in the state of Washington over in Spokane, and that's Gonzaga. We're very excited about that. Then in Wyoming, it's the University of Wyoming in Laramie. In Alaska, it's the University of Alaska up in Anchorage, Montana State University in Bozeman, and then the University of Idaho, which is in Moscow. So basically, this is a partnership or a collaboration between those 5 states and the School of Medicine. And this is really publicly supported medical education. So each of those states is providing the funding as though this was their School of Medicine. So that's the kind of publicly supported education that we have. So when we started WWAMI, there were really 5 goals, and these are still largely the goals for WWAMI that we have now, 44 years later. So some of that is having that access to publicly supported medical education, really working on increasing the number of primary care physicians or those generalists that you saw, and then looking at that distribution about where we have our physicians go practice. Having community-based medical education, so instead of people having to do all their training here at UW Medical Center or at Harborview, having them go out and do their education around the 5-state region. And I'll show you some maps here in a minute that shows that a little bit better. Continuing to work on expanding graduate medical education or those residency programs, as well as providing continuing medical education for all of our clinical faculty who are out around the region. And then really to do this without costing a lot of money. So to do this in a way that we're being very cost effective. So here's a map that's from 1974. I have been unable to uncover any maps from 1971 when we started. So this is as far back as I can actually find them. A couple of things I would just point out, things that have changed. First of all, when WWAMI started, we were actually working with the University of Alaska at Fairbanks. That actually changed when the University of Alaska really consolidated their health sciences programs in Anchorage. So that change happened in the 80s. And then if you just notice kind of the number of rotations that you see around the area. So on this particular map, the stars show where we had our first-year students at our partner universities. And then the green squares actually show where students were able to do in clinical rotations in their 3rd and 4th year. So you'll see we have 4 family medicine sites, we had 3 internal medicine sites, we had 3 pediatric sites, 1 OB site, and 1 psychiatry site. So that was, otherwise the students did everything in Seattle back in 1974. Now this is our map now. So just to try to orient you a little bit, since there's a lot more on the map now than there was in 1974, where you see the big blue squares, that's where students can go to do their required clinical rotations. And we'll talk about required rotations a little bit more in the curriculum part of this. Red squares show where we have graduate medical education or residency programs. The red dots show where residents can go and do rotations outside of some of the bigger communities, and we'll talk about that a little bit more specifically in a little bit. And then the other thing you'll notice on here, you'll notice there are some green dots. There are also places that have a pink W and a T with them. So these really denote some of our rural programs, and one of the student panels is going to be dedicated specifically to that. But I do just want to mention some of our rural programs that we have. So the green dots represent what we call RUOP, or the Rural Underserved Opportunities Program. This is a 1-month clinical opportunity for students between their 1st and 2nd year of medical school. As you can see, we have a number of those locations around the 5-state region. We have right now between 130 and 140 students per year who go out every summer to participate in that. The next thing are those pink W's, or RIGHT. We really love our acronyms. So RIGHT stands for WWAMI Rural Integrated Training Experience. So that's where students can go to those communities and spend half of their 3rd year of clinical training in that same community. That really helps them as far as getting an idea of what longitudinal experience clinically looks like. And then the last thing are the T's, which stand for TRUST, or Targeted Rural Underserved Track. So those students are actually admitted into that program. It's a comprehensive 4-year program where students are really matched with one of those rural communities where they'll continue to go back for multiple experiences over their 4 years, as well as doing some rural health classes along the way. So as you can see, there's been a significant difference over the last 44 years as far as what we're doing with that community-based medical education, so what we're doing outside of the big academic medical center here in Seattle. So how exactly have we made this work over the last 40 plus years? So really, WWAMI is the medical school for each of our states. Each state has an admissions committee, so physicians from that particular state who are interviewing the students from that state to admit them into medical school. The students then are completing their foundations phase or classroom phase of their medical education at their home state university. And here in the state of Washington, the students rank whether they want to be in Spokane or Seattle. Then when they're doing their clinical rotations, students have to do specific clinical rotations here in Seattle. But the other ones, they can do anywhere around that 5-state region, as you saw all those blue boxes around the map where they're able to go. And then, of course, we have all those residency opportunities around the region for students to go to after they finish medical school. So over the years, with what we've been able to do across that 5-state region, we've been ranked #1 by U.S. News & World Report in family medicine, rural medicine for the last 24 years, and primary care for 21 of the last 22 years. So it's really because of the high quality, cost-effective medical education that we provide, how we get our students out across that region, and then some of the success we've had with retaining people from their training to actually provide care around the region. So we talk about two different numbers when we talk about what's our return rate for the WWAMI program or for the School of Medicine. So we talk about student return rate. So if a student is from Washington State and comes back to practice in Washington State, we call that the state-specific student return rate. With a WWAMI student return rate is actually the number of practicing physicians from that 5-state medical school, basically over, if you will, or divided by the number of students that state put into the 5-state medical school. We call that the return on investment. So we have a return rate and a return on investment. And you can just see, compared to the national average, which is about 40%, especially with the return on investment, each of our states does very well as far as keeping medical students who have trained in their states practicing in their states, which of course is the goal of what we're doing with our teaching. So I want to transition now a little bit and talk a little bit more about what we have with graduate medical education or residency programs. So we know that once you graduate from medical school, you can't just go out and start seeing patients. So doing this graduate medical education or residency training is very important as far as creating practicing physicians. So we know that residents are much more likely to practice within a 100-mile radius of where they did their residency training than a medical student is to practice within 100 miles of where they went to medical school. So we know that there's a really important component to where people do their residency training. It's a little bit more challenging to create residency programs. You do have to have specific clinical resources to be able to train people. You have to have the faculty to do that. And then residents are actually getting paid while they're still doing their training. So it does cost some money to be able to do that, versus the medical students who are actually paying tuition as part of that. So what do we have around the 5-state region as far as graduate medical education or residency programs? We've worked very hard on our family medicine training programs, largely because we know with our very rural and frontier region, we need a lot of family physicians who can go out and practice in those areas. So WWAMI covers about 28% of the land mass of the US and only has about 3.5% of the population of the US. So we do have a lot of very rural and frontier areas. So in the last 40 years, we've created about 25 residency programs in family medicine. We have several more programs that are actually in the process of being developed with that. We also have internal medicine residency programs. Previously, we just only had internal medicine here in Seattle and in Spokane, and in the last couple of years, we have a new program in Boise as well as one in Billings. And then we also have regional rotations, so those red dots on that map, where internal medicine residents from here in Seattle can go out into the region and spend some time seeing what it would be like to practice in a small or rural community outside of Seattle. Then pediatrics, the residents that are here in Seattle go out and spend 2 months in right now they have 6 different sites around the 5-state region, and every resident does that during their 2nd year of training. And then the pediatric department created a new Alaska training track that just graduated its first residents last June. So those residents spend time each of their 3 years of training up in Alaska. The great thing with that particular training track is that 3 of the 4 graduates last year stayed in Alaska to practice, and of the residents who will be graduating this June, at least 3 of the 4 will be staying. The 4th one is looking at jobs up there right now. So as far as helping create that physician workforce that they need up in Alaska around pediatrics, that residency program is really doing what we want. Then psychiatry is actually a 4-year training program, so a little bit longer than the other 3. So we have our program here. There's also a new psychiatry program in Spokane. And then we have a track in Idaho. Those residents spend 2 years here in Seattle, and then they spend their last 2 years in Idaho. That program has now graduated its 5th class, and they've kept about 2/3 of the graduates in the state of Idaho practicing, which is great, because again, that's what we really want them to do. And then OB has some regional rotations that they do. Surgery previously had some regional rotations, and we're working on getting those going again for surgery. So that's just to give you a little bit of an idea about what we have as far as residency training around the region. This map isn't 100% up to date, but it's the most recent map I have. So you can see where the boxes are is where we really have core programs. And then the dots, again, are where residents can go to do rotations. So you can see we do a pretty good job of trying to get residents out into those communities where we want them to be doing their training and hopefully to practice sometime in the future. So our states, especially Alaska, Montana, and Idaho, have consistently been in the top 10 in the country as far as keeping the residents who train in those states practicing in those states. So we know, or we hope, the more of those residency programs that we can create across the region, the more we're going to be able to keep people in those states to practice. So the Wyoming residency programs, they joined us a little bit later when Wyoming joined the WWAMI program. So we're continuing to work on that with them to increase their return rate on that, and really trying to focus on recruiting and keeping some great faculty in Wyoming to help with that. So now I'm going to transition from that, and I'm going to talk a little bit about the curriculum, which is really, this is the biggest change that we've had in the WWAMI program since WWAMI started. So really, this was an amazing amount of work and collaboration across the 5-state region with numerous faculty, students, staff around the 5 states who participated in this. This was much different than when WWAMI started, when it was really, here's the School of Medicine, and we're going to go out and we're going to help all these places do this training. It was much more of a collaboration with everybody pitching in. And of course, we're very unique in the country in that we have a 5-state regional medical school. It does create a lot of great opportunities for collaboration, but also some challenges as you think about getting all of those people to agree on one thing that you're going to be teaching to the medical students. So why did we decide that we were going to change? Why not just keep doing what we had been doing that has been very successful? So as many of you know, especially since you've been coming to the mini medical school, there's been a lot of change as far as medical and scientific information, and that just continues to grow. There's been a lot of changes with technology and how patients interact with the healthcare system and with their physician. We also know that students nowadays actually learn much differently than I did when I went to medical school. There's a lot more information available to them, so they don't have to listen to me lecture to them because they can look everything up and say, well, that study you just quoted is out of date. You should be looking at this study. So we know that they learn in a much different way than when I went to school, certainly. Then there's been a lot of work done nationally looking at active learning and the importance of active learning and the retention of information if you're doing active learning. And then we really want our students to be ready to work with and adapt with the healthcare system as it continues to change over time. So those were some of the reasons why we wanted to work on changing our curriculum. So what's different in this new curriculum that we started in 2015 compared to the curriculum that we've had previously? So most of you think about medical school as being 4 years. That's what I told you, we go for 4 years. But we're really now talking about 3 phases of medical school. The first phase, called the foundations phase, is all done in the region or at whichever site you're assigned to for that particular classroom phase of the curriculum. Previously, students were only at their regional site for 1 year and then came here to Seattle for their 2nd year. So that was a big change for us to have the students out in the region. The other thing is having clinical experiences earlier in the curriculum. So our students now start actually with 2 weeks of learning how to do a history and physical examination and working with students or working with patients right at the beginning of medical school before they've even done any classroom learning. And then they work with primary care physician office throughout medical school, throughout those 18 months. So it's really clinical experience throughout medical school right from the first day. So everything is integrated between basic science and clinical science, even in the classroom. And then the students are actually in class 4 days a week, 4 hours a day, with no more than 1 hour of lecture. Those other 3 hours have to be active learning of some type. And then that 5th day is really their clinical day where they're doing something clinically. And then we have, I'll show you the blocks. It's 7 blocks that they go through to learn. And they have specific things like anatomy, pathology, pharmacology that go across all 7 blocks. And then we have specific themes that go throughout the entire 4 years of the curriculum. So this is what we call the fabric of the curriculum that just gives you a little bit of an idea about those themes or the things that we feel are really important to be integrated across all 4 years of the curriculum. And you can see across the top the 3 phases: medical science or the foundations phase, patient care, and then career and explore and focus is the last one. And you can see that we really have it bookmarked with primary care and scientific discovery. So really creating those physicians who are going to care for people and people who are making those important discoveries. And then you can see health equity, ethics and professionalism, quality and safety, communication and interprofessionalism, diversity and lifelong learning. So those are things that students will experience throughout all 4 years. So again, you can see with this depiction of how we came about with creating this new curriculum that it's not just Seattle in the middle with spokes going out, but it really is a collaboration across sites. And some of the important things about this is that this is a common experience for students across all the sites. So they have the same goals and objectives, the same syllabus, the same information or articles or preparation materials that they need to use to get ready for class. They're doing a lot of that active learning in small group settings. And then they're also doing all of their assessments at the same time with the same assessments across site. So it really is, even though it's at 6 different sites, what students are doing in that foundations phase is really common. So here are the blocks that we talk about in the foundations phase, which again is really integrated between basic science and clinical science. So the students started back in September with molecular and cellular basis of disease, which is a lot of the basics. So biochemistry, physiology are really included in that block. Invaders and defenders is immunology and microbiology. And then the circulatory system, which is what the students are in right now, is really cardiovascular, or your heart, pulmonary, the lungs, and then renal, which are the kidneys that they're doing right now. Then they have blood and cancer. Energetics and homeostasis is really the gut. Mind, brain, and behavior is neurology and psychiatry, neurosciences. And then life cycle and reproduction gets into OBGYN, urology, and really thinking about how do we develop from conception all the way through our entire life cycle. So this is just a picture of the students as they're doing active learning. So, if you guys were sitting in class, we might have some kind of a question up on the screen, and then I would ask you to talk to your neighbor to come up with the best answer. So here you can see the students interacting rather than just sitting in class, like I'm making you do right now. So as students are going through that foundations phase, that fifth day of the week, they're doing this Foundations of Clinical Medicine curriculum. So I already told you a little bit about that immersion, so those 2 weeks at the beginning of medical school where they're learning how to do a history and physical exam. Then every other week, they're doing kind of advanced clinical skills, so refining those history and physical exam skills. On the alternate week, they're doing their primary care clinic where they're spending a day that week out in a primary care office, basically using those clinical skills that they've learned in the office setting. And then their college tutorials are things like ethics, professionalism, where they work on specific cases. And then finally, at the end of that 18 months, they're gonna do a transition to the clerkships to really get them ready for the next phase, which is the patient care phase. So in the patient care phase, which is really, they'll start now kind of in March of their second year of medical school. They'll do what I call the 6 big clerkships. So internal medicine, family medicine, pediatrics, psychiatry, OB, and surgery. So that will really comprise the patient care phase that takes about a year for them to go through. The big thing that we're gonna be changing as the students get to that patient care phase is actually gonna be having more of the basic sciences back in the clinical clerkships. We do some of that right now, but we could do a lot better about bringing back in some of the basic sciences into those. And then also having them very competency-based, which is a little bit different than what we do right now. So we're pretty excited about those changes coming up in the patient care phase. And then the third phase is called Career Explore and Focus. So students still have some required clerkships that they have to do, neurology, advanced care of the undiagnosed patient, which is the same basically as emergency medicine, advanced inpatient, which is kind of a practice rotation for being a resident. We call it a sub-internship. And then advanced outpatient, which is something that's new, and we don't think that there are any other medical schools doing that. But we know that the majority of care is actually provided in an outpatient setting, not in an inpatient setting. So we really want our students to leave here being really competent in caring for people in a clinical setting. So that's a new thing that we're actually pretty excited about. Students will then have time to do electives, and they also have a scholarship requirement that they can really complete anywhere along the way in the 4 years, but they'll have specific time to finish that up if they need to in their last year. And then transition to residencies is something that's also new. That is taking kind of the last 2 to 4 weeks of medical school and making sure that people leave medical school with the skills that they need to be successful in residency training, whatever that training might be. So we're pretty excited about that last piece as well. So these are just some pictures of our students as they got ready for their new curriculum. You can see when they got their white coat, which is really a symbol that we utilize within medicine of people becoming part of medicine. And this was the class here in Seattle after they had gotten their white coats. So thank you for your attention, and I'm really happy to take any questions you guys might have.
I was wondering with a silver tsunami happening, how does geriatrics fit into your school?
Yeah, thanks. That's a great question. To become a geriatrician, people can do either a family medicine residency or an internal medicine residency and then go on and do a geriatrics fellowship. We actually have a wonderful geriatrics fellowship here in Seattle. We also have a couple of geriatric fellowships in the region at our family medicine residency programs. So we certainly have the training for that. I think one of the challenges that we all face is having enough people go specifically into geriatrics. So you'll see a lot, especially in internal medicine and family medicine, of specific training to care for an aging population, even though they haven't done a geriatric fellowship. So we certainly pay attention to that. I would say the other piece along with that is our palliative medicine, especially that we have here at UW-Medicine, and we do have 2 palliative medicine fellowships in the region as well. But certainly that's another piece of that aging population, is how do we help people towards the end of life make sure that they have a good death.
One area that I think probably is problematical along with rural areas in terms of recruiting people is low-income clinics. Do you have, you clearly do things to direct people to rural areas where you'd like them to serve. Do you have anything to direct them to the low-income clinics or other really challenging settings?
Yeah, thanks for that question. That's what we call our underserved care. So certainly we have lots of areas around the region that's underserved. Depending upon how you want to look at that, that can be a rural community, that can be an inner city population, that can be a specific population such as a Native population. So there are lots of underserved populations that we have within the region. So we do talk about RUOP, which is rural underserved. So some of the students actually do that 1-month clinical training between first and second year at, say, a community health center in an urban setting, or they might do it at a tribal location to really get at that underserved. Similar with TRUST, which is the Targeted Rural Underserved. So we do in each of those programs have that. And then the other piece we have is actually something that we call a pathway. So we have an underserved pathway. Any student within the School of Medicine can participate in that. They have very specific modules that they do online, specific events that we want them to participate in, and then we really try to tailor their clinical rotations in their patient care and in their career explore and focus phase around whatever underserved population they want to work with. So it could be that they would be at a tribal location, it could be that they would be at an inner city clinic, could be that they would be at a community health center somewhere. So we do try to work with students around that underserved care as well.
Of course, there's a new player on the block and at Washington State and their medical school in Spokane. How is that affecting your program, and is there going to be any coordination or cooperation there?
So as I said earlier, we have a new partner in Eastern Washington, which is Gonzaga, and that was after we had separated from our previous partner, which was Washington State University, when they planned their own independent medical school. So I can't speak exactly to what they're going to be doing because I'm not involved in their process. So we do know we have expanded our medical school. So we used to be 120 medical students in the state of Washington that are just from Washington. We're going up to 160 this coming summer. So we continue to work on how do we make sure and have enough of those clinical rotations for those students to be able to do that, and then working to really increase the number of residency positions, because we know we want them to be able to do their residency training as well to keep them here. So the other thing, just so folks know, is that we do already have a second accredited medical school in Washington State, and that's Pacific Northwest University of Osteopathic Medicine, which is in Yakima. So they actually opened back in 2008. think I got that year right. And so they're just having their first graduates finish residency training and come back to be able to serve the population. So should we take a break if folks don't have other questions?
Just make one brief comment to the person who asked about the care of the underserved. And we also have, they operate the Pioneer Square Clinic, which is down in Pioneer, and we have our medicine residency program has residents who do their continuity training right in the Pioneer Square Clinic, because we think it's very, very important to serve many different populations of patients, and we have lots of outreach into that area in our Pioneer Square Clinic. So I think we're going to take a 2-minute break, and we will invite our medical student panel up here and have them talk to you about their experiences.